الندوة إن شاء الله القادمة الندوة السادسة عشر بعنوان قلب الرياضيين رؤى من الموجات فوق الصوتية للقلب. رئيس الندوة الأستاذ الدكتور محمد مسعود بورغضة، محاضر بمعهد علوم وتقنيات الأنشطة البدنية والرياضة جامعة قسنطينة الجزائر. المتحدث الدكتور ديفيد أوكسبور، جامعة ليفربول المملكة المتحدة. مقرر الندوة بيعتذر. طبعا برضو بيكون موجود معانا في الترجمة الدكتورة أمنة مرقسي، دكتورة جمعون ريان.
بسم الله الرحمن الرحيم. شكرا للدكتور مغازي محمد. كل الشكر والتقدير لمنظمي المؤتمر الرياضة والصحة أمن قومي عربي الذي ينظم من طرف جامعتي الإسكندرية وجامعة قسنطينة والأكاديمية البريطانية لعلوم وتكنولوجيا الرياضة. يشرفني أن أترأس هذه الندوة، ومن المفروض كان أن يرافقني الأستاذ الدكتور بصيري مصطفى، والآن سينوب عنه. هذه الندوة بعنوان قلب الرياضيين رؤى من الموجات فوق الصوتية للقلب، يقدمها الدكتور ديفيد أوكسبورغ من جامعة ليفربول جون مورس، ويسعدني أن أطلع على آخر ما توصل إليه. والكلمة الآن لمقرر الجلسة، فليتفضل مشكورا.
محمد.
لا دكتور عزمي، اتفضل دكتور عزمي.
احب اتكلم يعني.
اتفضل دكتور عزمي.
حضراتكم النهارده وهيبقى معانا دكتور ديفيد اوكسبورغ من جامعه ليفربول، وهو احد المتخصصين في عمل القلب اثناء المجهود البدني، وهو المسؤول عن القياسات الخاصه بفريق ليفربول. اسمح لي في الاول بس هنا افتح لديفيد عشان هو موجود معانا يا محمد.
فتحت له يا دكتور.
Hi David.
Hi.
So you're in England or you are in Canada right now?
I'm in England. Didn't end up going to Canada, unfortunately.
Okay, so دكتور اوكسبورغ كان عنده رحله لكندا يعني، ولكن للاسف ان هي ظروف الطيران وظروف كورونا ما قدرش يروح، فهو حاليا يعني هيبقى معانا من ليفربول ان شاء الله. Okay, so Dave, we would like to welcome you to Alexandria University conference, and we'll give you this. You can just start share your slides, and we'll be grateful just to listen to you.
Wonderful, thank you, Asmai. Okay, let me see if I can start to share.
دكتور عزمي.
نعم.
طبعا الدكتور مقرر الندوة مش موجود، معتذر لظروف خاصة. حضرتك برضو معانا.
طيب، هي فهم المترجمة هي هتتولى عملية الترجمة، وأنا لو في أسئلة أو حاجة في الآخر، عشان الأسئلة ممكن بس ما بيبقاش الترجمة بتاعتها واضحة، فأنا ممكن أتدخل في الجزء الخاص بالتفسير.
تمام، اتفضل.
If I think we see your slides now, if you can just put it in the presenters.
I will do in a minute, just two seconds, please, Dr. Fazal.
Yeah, take your time.
Okay. Wonderful. So let's start the slideshow here. Can we see this?
Yeah, looks great now.
Perfect. Okay. So firstly, I'd like to thank you, Professor Fazal, and the organizing committee for giving me this wonderful opportunity to speak with you guys about the athlete's heart, how the athlete's heart adapts and changes to chronic exercise, and what we've learned, I guess, from imaging, particularly in this field alongside echocardiography. So I'm Dr. David Oxborough. I'm a reader in cardiovascular physiology at Liverpool John Moores University and the Liverpool Centre for Cardiovascular Science. I'm also a clinical echocardiographer. So I'm a fellow of the British Society of Echocardiography. I sit on the education committee for the British Society of Echocardiography, and I still clinically practice 2 days a week. That does mean that I'm in an interesting position, because I'm not only undertaking research in this field, but I'm also doing the practical application as well. In terms of screening athletes, I've been doing pre-participation screening from a clinical perspective for the past 20 years. I must have scanned over and screened over 20,000 athletes in my time. And we've had some wonderful links with Egypt in the past. In fact, in Cairo, we've got links and helped to set up their Athletes Heart Centre at the Wadi Al Nil Hospital, of which I'm undertaking work and doing some screening at the moment. So that's me. I'm going to start with the question is really, why do we study the athlete's heart? Why do we really care? Now, I'm sure we've all seen this type of thing happening in the public domain and in the media, but young people between the age of 14 and 35, and more likely those who are athletes, are predisposed in some way to sudden cardiac death. And the prevalence of sudden cardiac death in the athletic population is variable from different data sources. But essentially, it could be as high as 7 in 100,000 athlete participation years. Now that doesn't seem a lot. It's 1 in 14,000 athletes who may die from a cardiac related condition. But if you think about the issue here, this is not just about the individual who is young, but this is also about the wider community. It's a tragic event. And equally, many of these conditions that cause sudden cardiac death are inherited, and therefore it has an impact on their family and their siblings and their children. So it's a huge issue. It is relatively rare, but it has huge impact. Now, in terms of the demographic, the male athlete is more likely to suffer from sudden cardiac death. And if you are of Black, African or Afro-Caribbean ethnicity. So I'm aware of where we are, and the audience is very mixed. So I'm going to try and look at this from a bit of a lay person, but at the same time offer some scientific evidence here. But this was a study to try and establish what were the causes of sudden cardiac death in the athletic population. And this is one of the better studies because it's a prospective assessment. It assessed directly the hearts of 357 athletes who had died between 1994 and 2014, and they were analysed by the pathology unit at St George's University Hospital in London. Now, Mary Shepherd, who's the lead author or the senior author on this study, undertook the post-mortem analysis, and she's a world expert in sudden cardiac death syndromes and what constitutes these diseases. And they reported the prevalence of cardiac conditions in this population. Now, I don't want to overburden you with these different types of long names and conditions, but essentially what we've got here is we've got a number of inherited cardiac conditions. 42% were something called a sudden arrhythmic death syndrome. Now, what this is when you open the heart, you have a look at the heart, there is nothing structurally abnormal here. And this is likely related to ion channels within the cardiac tissue. And these ion channels can cause things that would trigger an arrhythmia and potentially a fatal ventricular fibrillation. Other causes include hypertrophic cardiomyopathy. Hypertrophic just means increased muscle mass. Cardiomyopathy is disease of the heart. Dilated cardiomyopathy, where the ventricles get bigger and dilated. and also this condition called Arrhythmogenic ventricular or right ventricular cardiomyopathy. What they have in common.
Excuse me, sir.
Dave is a good time
Excuse
for.
me, sir. I would like to translate to the audience now. Thank you.
Okay.
ولقد تناول الدكتور في مداخلته موضوعا هاما تمحور حول قلب الرياضي ورؤى الموجات فوق الصوتية للقلب. ففي البداية لقد تطرق الدكتور إلى ماهية توقف القلب المفاجئ باعتباره حدثا مأساويا، حيث ترتبط معظم أسباب الوفاة المفاجئ بأمراض القلب خاصة الوراثية منها، كحالات الاعتلال عضلة القلب. فبين سنوات 2014 و 1994 قد توفي ما يقارب 357 رياضي. وشكرا. You may proceed, sir.
Thank you. So these conditions have some things in common. Cardiomyopathy just means disease of the heart muscle. But the other factors are elements that structurally change the heart itself. And that be, it's either thickened muscle, it's a dilated cavity, or it's an abnormal right ventricle, i.e. the side that feeds the lungs. And that's important to remember. So I don't know whether you can see these playing. These are ultrasound images of the heart. This one here on the top left is an image with the left ventricle. Can you see my cursor, by the way?
Yes, we can see it.
Yes, sir, we can see it.
Thank you. So this here is the left atrium. This is a left ventricle. It's dilated and it's big. And this is a very clear case of a dilated cardiomyopathy. The case on the top right here is one with a big, thick septum. So this is a 4-chamber view. We've got the left ventricle here, the left atrium here, right atrium here, and right ventricle here. And this is abnormal because of the thick muscle. And this acts as a substrate for arrhythmia. And the image at the bottom here is one of a arrhythmogenic ventricular cardiomyopathy. And you can see this is a right ventricle at the top here. It's very dilated and it doesn't seem to function properly at the top here. You may have to believe me if you've not been looking at these images what that means, but these are what we call very clear-cut cases of cardiomyopathy. Now, this is an athlete's heart, okay? The one on the left is a 4-chamber view, and we can see the left atrium, left ventricle, right atrium. And this is a normal non-athlete's heart. And one thing that I want to draw your attention to here is if you look at this scale down here, this is 18 centimeters. This is a scale down here of a non-athlete. It's around about 13 centimeters. This heart is much bigger. And chamber enlargement is ubiquitous in the athletic population. And it's a major finding. And that makes it a very difficult challenge when we're trying to differentiate from this type of disease. So we have these two entities. We have the athlete's heart, which is enlarged in some ways, of which I'm going to describe in some detail. And we have inherited cardiac disease. Now, by definition of an elite athlete, if they are going to present with disease, it's often of a really quite mild phenotype. They may have this genotype, but they have a very mild phenotype. And that's because if they had the structure, like you saw in the previous images, they're not going to be able to perform at a higher level of sport. So it's often a very mild phenotype, which makes it even more difficult to differentiate. And if we're dealing with elite athletes, then a marked phenotype is often present because they've got really high training volumes. And the nature of this talk really, from this point onwards, is going to be related to the athlete's heart and how that adapts and how we can then think about what is normal and what is abnormal. Now I'm going to just play a video while the translator again may want to summarize the beginning of this talk. It is a video. I'll turn the volume down. It's a video of a very famous Egyptian who we screened here in Liverpool on his first day of Mohammed Salah.
ترانسليتور ممكن حضرتك تترجمي الجزء الخاص في اثناء الفيديو وهو شغال لو سمحتي.
Okay, yes. وكذلك لقد تناول الدكتور على أن القلب يهدف تقديم القلب يهدف قبل مشاركة الرياضي للتأكد من مدى خلو أي عرض وإمكانية التكيف الفيزيولوجي مع الحالة. فمن المهم فهم قلب الرياضي وكيف يتكيف مع التدريب. وهنا يؤكد الدكتور على أهمية التصوير القلبي وخاصة الموجات فوق الصوتية للقلب. فلدينا الشخص الرياضي يكون القلب أكبر وتكون جدران القلب أكثر سمكاً وتكون حجرات القلب أكبر إلى حد ما. وشكرا.
So can I resume?
Yes, you may.
Okay, so that was a wonderful day, of course, screening Mohammed Salah, and we go back to Liverpool every year and do his and the full team's cardiac screenings, and are very, very important in ensuring they have normal hearts. And I can tell you, Mohammed Salah has a very big heart. Okay, so let's start with the chambers of the heart. So the left ventricle is very, very important in determining normality in the athlete because of the conditions that predispose to sudden death, such as hypertrophic cardiomyopathy and dilated cardiomyopathy, where they predominantly affect the left ventricle. So when we're thinking about the athlete's heart and its development, it's actually quite a complex phenomenon because it's not straightforward in terms of you just expect certain enlargement. It's very dependent on a number of different demographics, and these include gender, age. We know that young athletes, even at the age of 13, 14, start to develop changes to the heart that make them bigger and more muscular than the heart of non-athletic or structured athletes in a child population. We also know that when you move into a master's level, so over 35 years old, then the heart is also adapted and changes and often reaches a point of peak and saturation. We know that ethnicity plays a really important part in terms of the heart itself and the electrocardiogram. The training volume, so the amount of exercise you do and the intensity of exercise you do, will determine the type and adaptation of the heart and the left ventricle, and the training type as well. And I'm just going to touch on a little bit about the training type, because when we talk about how the heart does, or the left ventricle does adapt, we often think about a very dichotomous process of those wrestlers, those bodybuilders or strength-trained athletes may have different hearts to those who cycle or run. And I want to put this concept to you, which is really important, and it's very difficult to put it across in a lay way, but it is important to think about it as what it is. So this is the left ventricle here in the middle, and there are types of hypertrophy which are normal in terms of normal adaptation, and hypertrophy is just an increase in mass of the heart and of the left ventricle to accommodate for different load changes that occur. Now, a type of hypertrophy called concentric hypertrophy, which is where you get an increased wall thickness, but a normal cavity dimension, which is this one here, is usually a manifestation of what we call an increased afterload. So the afterload is what the ventricle's got to work against. So if you have a high blood pressure, if you've got a valve that's stenosed or thickened, the heart's going to get thicker but the cavity is not going to change. And we call this concentric hypertrophy. Eccentric hypertrophy is where you get an increased, first of all, cavity dimension. So the cavity gets bigger, and you get a concomitant increase in wall thickness to balance the wall stress within that ventricle. And this is driven by an increased preload, which is the amount of blood in the ventricle. So it's the amount of blood at end diastole. And if we think about an athletic population, this here of an increased blood volume, well, we know that through training, plasma volume increases. This is probably likely to be the primary manifestation. It's very difficult to establish why there would be increased afterload, but there are some studies, and in particular seminal work back in the 1970s, that try to explain that this is still a normal phenomenon. And this is a study. And this, if you go to the textbooks of sports science and athletic adaptation, you will see the Morgan-Roth hypothesis. And the Morgan-Roth hypothesis states that those athletes that train through strength and resistance will develop concentric hypertrophy, whilst those who are engaged in endurance or dynamic activity will develop eccentric hypertrophy. And it comes from this data set. And it's a little bit busy, and I do apologize, but I'll talk you through it. What we have on the left here is the internal dimension of the left ventricle. And we've got a number of different types of athletes from this study: swimmers and runners, and wrestlers, and then normal sedentary individuals. And you can see from their work that the end diastolic cavity, so the cavity dimension, is much bigger in the swimmers and the runners, i.e. those of endurance or dynamic activity, compared to wrestlers. If you look at the wall thickness, it's the other way around. Those athletes who are engaged in wrestling or strength train have much higher wall thicknesses. Now, this is an interesting concept, but this is where they drove the idea of concentric hypertrophy in strength trained athletes. And their rationale behind this was, of course, that you only get concentric hypertrophy if you increase the afterload. And when they looked at the blood pressure of these athletes lifting weights, their blood pressure went up to 360 over almost 150. So this was very, very high blood pressure. And you could argue that that would be a stimulus for concentric hypertrophy.
David, it's a good time.
Excuse me. Yes, I'm going to translate. Thank you. وطبقا للتغيرات التي ذكرناها سابقا كالزيادة في الحجم وسماكة جدران القلب التي تسمح للقلب بضخ كميات كبيرة من الدم مع كل ضربة قلبية، ويسمح الحجم الأكبر من الدم مع كل ضربة من ضربات القلب للقلب بالنبضان بشكل أبطأ، مما يؤدي إلى نبض أقوى وأبطأ، والذي يمكن أن يشعر به والذي يمكن بالطبع أن يشعر به في المعصم وأماكن أخرى من الجسم. وكذلك تناول الدكتور في محور آخر جزءا حول هيكل البطين الأيسر، أنا وهو معروف بالنسبة لنا، وحسب فرضية مورغان روث يؤدي تدريب القوة إلى تضخم البطين الأيسر. وشكرا. Proceed, sir. You may proceed, sir.
Wonderful, thank you. Okay, so let's think about that Morgan-Roth hypothesis, and let's look at both limbs, i.e. the concentric and the eccentric. And I'm going to go towards the eccentric first, and these endurance athletes. So the slide I have here is just showing you that actually, if we look at the yellow is physical activity, but if you look at the daily recommended individual who is non-athletic, they only use a very small proportion of their time to undertake physical activity. Team athletes a little bit more, but your endurance athlete takes a lot of time, and that's physical stimulus is there for a long period of time. And we know that this type of activity increases your plasma volume and it does increase your left ventricular size. If we look at this is a Mitchell's classification for different sports, and they've classified them into dynamic across here and static on the y-axis here. And if you look at the top right here, where you're looking at the highest static and the highest dynamic, you've got sports like boxing, canoeing, cycling, rowing, triathlon. And these sports occupy often the most time in terms of the stimulus that is there, because you've got a static element and you've also got a dynamic component. To simplify that, André Lagersh, who's a pioneer and an academic in this area, put forward this concept that was it was simpler and easier to understand, in the fact that if you've got a high intensity or amount of training, then your training volume is high. And therefore the fittest have the greatest degree of cardiac remodeling. And that makes sense. And so when we look at the Morgan-Roth hypothesis, utilizing this old technology, the eccentric hypertrophy seems to make sense. It makes sense. There's a bit increased plasma volume, and it would it would be a sensible assumption to expect a bigger cavity and a concomitant increase in wall thickness. But when we think about this concentric hypertrophy side, we've got this element of what is the afterload, and the wall stress is essentially the afterload. And this is what we call the transmural pressure, which is dependent on the pressure within the chamber itself. But what we forget is it's also dependent on the intrathoracic pressure. Now, there's a wonderful study here by Mark Heikowski back in the I think it was late 90s. And he and the team had a number of different measurements that they took. They looked at the brachial artery pressure, and they also managed to get esophageal pressure. And I don't know how they managed to get ethics as well, but they also managed to do a transesophageal echocardiogram through the mouth here at the same time. This is a transducer that, instead of imaging the heart from the front of the chest here, they looked from the back down the esophagus. And they only had 5 individuals, but they got these 5 individuals to push and do leg presses. And when they did the leg presses, as you would do, they bared down and did a Valsalva maneuver. And it was very, very interesting what they observed, because when you leg press for 2 to 3 seconds with a Valsalva maneuver, there is no increase in LV wall stress. The blood pressure went very high, but the intrathoracic pressure counterbalanced that. And so the actual pressure on the heart wasn't there, or increase wasn't there. So there isn't a stimulus of afterload increase in these strength trained athletes. And we carried out...
Excuse me, doctor. I'd like to translate now.
Yes.
Yes. وفي هذا الجزء لقد تناول الدكتور وأوضح لنا من خلال محاضرته بعض الأجهزة والتقنيات التي يمكن من خلالها قياس عضلة القلب وضغط الدم الواقع عليها. وشكرا. You may proceed, sir.
Thank you very much. So we carried out a systematic review and a meta-analysis of looking at the training mode and the imaging modality on the morphology and function of the athlete's heart, and specifically the left ventricle. And it was very apparent that in those endurance-trained athletes, they had bigger cavities than sedentary controls. So we're looking at this LV-EDD here, much bigger. If you look at the wall thickness, though, they were bigger than the non-athletes, but the resistance trained, which is the concentric limb of Morgan-Roth, were not increased compared to the endurance trained athletes. So it's now quite clear that actually there is not this concentric hypertrophy, and there's a good reason why I've kind of taken my time to go through this, and that hypertrophic cardiomyopathy is essentially one that thickens the walls and therefore increases the the element of concentric hypertrophy. So if we know that our athletes, even if they're involved in strength-trained work, they do not develop concentric hypertrophy, i.e. it's rare, then that helps us with our differential diagnosis. And so further work that we've undertaken, here we've got a host of rugby players, and we've also got some elite cyclists. And just to explain these graphs here, the blue dots are the rugby players, and the orange dots are the sedentary controls. And any of these quadrants up here based on mass and wall thickness is concentric hypertrophy up here. What you see is actually most of them have normal geometry, with some eccentric hypertrophies in this quadrant here, just a couple. And when you look at cyclists, if you look at the concentric, only a small percentage have concentric left ventricular hypertrophy. Most have normal geometry, and some have eccentric, which is a dilatation. So on that note, I'm going to play another video. So I think at this point we'll just summarize the whole of that section, if that's okay. Can you hear me still?
So would you like the translator to translate now, Dave?
Yeah, well, I'll just summarize myself, and then quickly we'll go into video, and then we'll translate it then. Is that okay?
اوكي سوشي اوكي هو بيقول لحضرتك يعني خلال هو هيعمل سمري للسكشن دوت وبعدين هيران فيديو فخلال الفيديو حضرتك بقى بيعمل
Yes, thank you. I understood that.
Okay, so the key point from this is that concentric hypertrophy is rare. Okay, eccentric hypertrophy is more common, in particularly endurance trained athletes, and the differential from this hypertrophic cardiomyopathy is less challenging because it's very unlikely that an athlete will present with concentric hypertrophy. So I'm going to move on to that video, and if you can translate then that would be fantastic.
Could not hear the sound.
هو بيقول لحضرتك الترجمه بتاعت السكشن اللي فات لو سمحت.
وكذلك لقد تحدث الدكتور عن تضخم الباطين الأيسر وهو انتفاخ وتغلظ أي تضخم الذي يمكن أن يصيب جدار الحجرة حجرة الضخ الرئيسية بالقلب، ويفقد جدار القلب المتضخم مرونته، وقد يؤدي ذلك إلى زيادة الضغط للسماح للقلب بملء حجرة الضخ لإرسال الدم إلى بقية الجسم. وفي نهاية المطاف قد يفشل القلب في الضخ بالقوة التي يحتاج إليها الجسم. شكرا.
Okay, so that was just a short video identifying the work of Cardiac Risk in the Young, which is a charitable organization here in the UK. And they identify that 12 young people every week die from sudden cardiac death. And what I really wanted to highlight here is that it's not just the athletic population, but also sedentary and normal individuals, non-athletic populations also have these conditions, of course. Okay, so I'm going to move on to left ventricular function. I'm conscious of time. I think we're okay at the moment. So we've talked about the structure and the way that the left ventricle adapts in athletes, but what about the way it functions? Because that is really, really important, particularly in differentiating these athletes that have got a dilated ventricle, because there's this condition that I presented at the beginning called dilated cardiomyopathy. And we've also established that our athletes develop often dilated ventricles. So how might we differentiate the difference between the two of them? Well, we've put forward a guideline update for the practice of echocardiography in screening sports participants. And this was a joint policy from the British Society of Echocardiography and Cardiac Risk in the Young. And we have a number of sections in there, but they fundamentally have an overarching algorithm. And this overarching algorithm allows us to try and work out how best to go through an assessment of the athlete in terms of determining whether they have disease or whether it's just a normal physiological adaptation. So let me just work through here. I'm not going to go into a huge amount of detail. Again, I'm conscious of the mixed audience, but if we've got eccentric hypertrophy, which is what I've talked about, and that's more common than concentric, then you have to go down this line here, and all of these indices are functional indices. And if the function is depressed, then you may consider that this is pathology. You have to correlate it with clinical data, including the ECG or symptoms and demographics and family history. But essentially, the key is the functional assessment. There is one problem here, and that is this measurement here of ejection fraction. Now, I hope you are all, and if you're not all conversant with this term, then you will be hopefully by the end of this talk. But the ejection fraction is just the percentage of shortening within the ventricle. So it's classed as a percentage. And a normal ejection fraction in a male is around about 52% to 80%. And this is a really important marker of function. So when we've gone through this structural assessment of the heart, we have to look at the ejection fraction. But there is this thing about the ejection fraction that is often overlooked. And so the ejection fraction is actually calculated as the amount of blood, so the end diastolic volume, minus your end systolic volume, divided by your end diastolic volume. So it's just a percentage of the blood that leaves the heart. And if you've got a really big ventricle, if you look here, this one's 180 mils, which is not uncommon in our athletic population. And they go down to about 100 mils when it's contracted. That ejection fraction is 44%. Now that's, according to what I've just told you, is abnormal. But look at the stroke volume there. It's 80 mils. And when we assess someone at rest, 80 mils is absolutely adequate to maintain normal perfusion and tissue perfusion. Conversely, look at this one on the right here. You've got a very small ventricle, a very normal ejection fraction, but a very low stroke volume. So this ejection fraction parameter is very dependent on the size of the ventricle. And when you've got a heart that physiologically remodels and changes, it makes sense. And actually, so this ejection fraction may be low as part of a normal physiological process. And that's the case. Here we have work by Abagel. This is back in early 2000s. They had two cohorts of cyclists from the Tour de France. And what they did demonstrate here, this is your chamber size across here, and this is your ejection fraction on the y-axis. They demonstrated that the cyclists had bigger chambers.
Excuse me, doctor.
Yes.
Can I translate?
Sure.
Thank you. وكذلك لقد تطرق الدكتور إلى وظائف البطين الأيسر والتي قد تتمثل في وقد يتمثل دور البطين الأيسر بضخ الدم المحمل بالأكسجين والعناصر الغذائية إلى جميع خلايا الجسم عبر ما يعرف بالدورة الدموية الكبرى. حيث أن الدورة الدموية الكبرى عبارة عن انتقال الدم من القلب إلى جميع الجسم باستثناء الرئتين، لأن انتقال الدم بين القلب والرئتين يعرف باسم الدورة الدموية الصغرى. فكذلك تطرق إلى أنه عند انقباض عضلة القلب يتدفق الدم المحمل بالأكسجين إلى الأذين الأيسر ومنه إلى البطين الأيسر عبر الصمام التش. وشكرا. You may proceed, sir.
Thank you very much. And from this study, you can see that a number of athletes had, and in fact, it was 12% of these cyclists had an ejection fraction less than 52%, which creates this terribly difficult diagnostic dilemma in terms of differentiating from disease. Particularly, they're dilated and they don't seem to function very well. If you look at the work that we did on elite cyclists, we had 64 elite cyclists and 65 sub-elite cyclists. You can see that the range of ejection fraction was from 45 and 48 compared to non-athletes. So there was again 12% or around 12% of our athletes with low ejection fraction. I don't know whether you're used to looking at these images. I'm sure there's some people in the audience who are, but this is a ventricle that doesn't seem to be functioning very well. Okay, this is a football player, another Liverpool player, and the ventricle just doesn't seem to contract as well. It's dilated, and when we look at the size, it's 59 millimeters, which is a little bit big, but the ejection fraction was 47%. And these are measurements of, this is what we call tissue Doppler. This looks at the movement of the ventricle. These values are all very, very low. So what do we do? What do we do when we've got a heart that is functioning quite low, and yet it's big, and we have this risk of dilated cardiomyopathy in the athletic population? Well, exercise is key, and we have a table here where we can exercise, and we can start to get our athlete working away. We can try and collect our data during exercise. The image is actually very, very good, because the table tilts over to the side and allows you to get optimal images. Current data, and I'm going to show you some work by Lynn Miller from St. George's, but they suggest that an EF increase of 11% at peak exercise is a normal response in an athletic population. And it comes from this paper here, and this was published in Heart last year, and we are involved in trying to determine the differentiation between athletes' heart and dilated cardiomyopathy in those individuals with low ejection fractions. And this was the algorithm, or I guess infographic, that came out of that. In that, if you go down the line with ejection fraction, in this case less than 55%, they're dilated ventricles, you can look at obviously things like biomarkers, blood biomarkers, ECG, Holter, but exercise echo is in there as well, and independently predicts and differentiates between the two entities. An increase of 11% at peak exercise, but also a value greater than 63%, is consistent with physiology, whereas lower or less than 11% and a value, absolute value less than 63%, is more consistent with pathology.
Excuse me, doctor.
Yes.
We are now going to translate to the participants, please.
Oh, perfect. I'm going to play a video whilst you do that. Is that okay?
Okay.
And then can we summarize at the end of that as well?
Okay, of course.
Because that's the end of that section. Okay, thank you.
إذا حسب الفيديو الذي أشار أو عرضه الدكتور ديفيد أوكسبورغ، فإنه أوضح لنا كيفية تحفيز عضلة القلب للرياضي من خلال استخدام تكنولوجيا حديثة والمتمثلة في البروتوكول الذي تم عرضه قبل قليل. كما قد ذكر الدكتور وحدثنا عن مصطلح أو مفهوم الكسر القذفي، إذن هو مقياس لنسبة الدم الذي يغادر القلب في كل مرة ينقبض فيها. إذن ينقبض القلب وينبسط، حين ينقبض القلب فإنه يقذف الدم من غرفتي ضخ الدم أي البطينين، وحين ينبسط القلب فإن البطينان تمتلئان مرة أخرى بالدم. ومهما بلغت قوة انقباض القلب فإن القلب لن يستطيع ضخ جميع الدم خارج البطين، حيث يشير مصطلح الكسر القذفي إلى نسبة الدم التي يتم ضخها من خارج البطين الممتلئ مع كل نبضة. Thank you, Doctor. You may proceed your symposium.
Thank you very much. Okay, so with that, I'm going to move on to the last section of this talk and just touch on the adaptation to the right side of the heart, which is often overlooked. So I mentioned to you previously about this condition called arrhythmogenic right ventricular cardiomyopathy. So it is a big mouthful. We acronym it, abbreviated as ARVC. Now, in the past, this condition was seen to predominantly affect the right ventricle. It's defined as this fibrofatty replacement of the myocardium. So you end up with this, it's a desmosomal type of genetic condition. The myocardium is replaced by this fibrofatty substance, and that acts as a substrate for arrhythmia. We have found out more frequently and more recently that the condition actually involves the left ventricle as well. And in fact, in 85% of cases, it's a biventricular involvement. It is a really interesting condition because there is this association between environment and genetics with arrhythmogenic ventricular cardiomyopathy, in that the more exercise you do it, there is a small proportion of the population that develop this condition, even if they don't have the genetic predisposition. So there is this essentially an environmental issue here. But equally, there is also when you exercise with this condition, it can act as a very clear trigger for sudden cardiac death. And this is one of those conditions that is more prevalent in an athletic population, and certainly at the point where the sudden cardiac death occurs, it's usually during exercise. So how do we assess the right ventricle? Well, we can image it again with echocardiography. You can see the right ventricle here on the side. What we're looking for in this condition is often a dilatation. This is the right ventricle here, a dilatation of the outflow tract here, and it's usually disproportionate to the right ventricle here. And also you can see maybe some aneurysm formation as well sometimes in this condition. So this is the outflow, this is the inflow, and the outflow bit here is where we can assess. Let me just go back to here. Can we run this here? Yeah. So this is the right ventricular outflow tract here. So we can really clearly measure it and look at it and get a lot of information about the structure and function from that. We can rotate our transducer around and we can get to look at this short axis view, and this is the right ventricular outflow tract here. So we can really clearly look at the chamber itself. And we can tilt up and we can look at what we call the infundibulum of the right ventricle outflow tract here as well. We can rotate different views and we can go around and look at the inflow now. So this is the inflow of the right ventricle. And so using this two-dimensional technique, we get to look at a very comprehensive assessment of the right ventricle, which is really important when we're thinking about the athletic type of remodeling. Just look at this graph here. This graph shows you the right ventricle and the wall stress. Remember, the wall stress is the pressure within the chamber, and is related to the pressure, the radius, and the wall thickness of the chamber. But in endurance athletes, if you compare it to the left, there's actually a disproportionate wall stress in athletes compared to non-athletes, and their volumes are much bigger. So we often see very big right ventricular adaptation, which again creates this differential diagnostic dilemma with this condition of AVC. I'm just going to present a couple of papers from the public domain. Flavio D'Ascenzi here looking at right ventricular remodeling in a number of Olympic athletes, and showing you these are the outflow tract dimensions in females and males, and the outflow different views, and this is function here. And you can see that a significant proportion have quite enlarged right ventricles, and anything over 35 millimeters here is actually consistent with a diagnosis of AVC. So we do have this a percentage of athletes who have chambers that are consistent with this condition. And you also see a certain percentage, albeit smaller, of athletes who have poor function as well, further compounding the dilemma.
Excuse me, doctor. I'm going to translate.
Yes.
Thank you. إذا كما ذكر الدكتور ديفيد أوكسبورغ أنه بالنسبة للبطين الأيمن يقول الدكتور أنه يتكيف أيضا بشكل كبير مع التمرين. وهنا تظهر أهمية التقييم الوظيفي، حيث تم تسليط الضوء على الارتباط بين التمارين الرياضية واعتلال عضلة القلب الناتج عن انتظام ضربته، وبالتالي فإن التقييم الشامل مهم في هذه الحالة، وهذا حسب النماذج والبيانات التي أظهرها الدكتور بتوضيحه للفرق بين حجم كل من البطينين الأيمن والأيسر لدى قلب الرياضي ولدى قلب الشخص أو الفرد العادي. Yes, doctor, you can proceed your symposium.
Thank you. So just to kind of to almost reiterate and to present further evidence of the size of the right ventricle, we looked at a number 102 endurance athletes and demonstrated that chamber size in over 50% of them was bigger than what we had a cutoff for a non-athletic population. What is key here, and this is something I think as a reasonable take-home message, is that the outflow of the right ventricle, remember you've got the outflow and you've got the inflow, the outflow had a balanced dilatation compared to the inflow. And we know that in this condition of arrhythmogenic ventricular cardiomyopathy, it tends to affect more of the outflow. So this is a really key finding. Work from Abbas Zaidi, St. George's, and ourselves looked at the chamber size in Black, African, and Afro-Caribbean athletes. And this is the cutoff that we use for this condition. These are the values. And you can see again that a percentage of athletes had a cutoff chamber that was consistent with the criteria, the major and the minor criteria for this disease. What is interesting though is it was not different between ethnicities and between males and females. So that helped us a little bit in terms of being able to apply a very similar value and phenomenon to the athlete as a whole, irrespective of demographic. There were some absolute differences, and this was work that we carried out with Stanford, and this was looking at gender differences in ventricular remodeling, both left and right. But what we have on this graph here is that the absolute values for males were always much higher than females. But when you actually index for lean body mass, here, everything tends to normalize. So this is the absolute value. Males had bigger values than females, but when you index to lean body mass, not body surface area, it comes back to normal. And the same for the right atrium. Finally, in terms of our studies, we thought, okay, well, what should we do here? We should look at a population of athletes that meet the criteria for this disease and see if they have got functional differences. And we looked at 400 athletes that met the criteria for this disease, i.e. the structural criteria, and actually some of them had lower function as well. So some parameters were not discriminatory. However, these, TAPSE, which is looking at the movement longitudinally, and this RV-LV ratio and fractional area change were normal. So that helped us in terms of being able to differentiate. I think this is my final slide, and I think when we go to an athletic population, we've got to think about when do we worry in terms of thinking how can we differentiate this normal adaptation from this condition of arrhythmogenic ventricular cardiomyopathy. The first step is ECG. That's very, very important. In this condition, you can get T-wave inversion in V1, V2, and V3. You can also develop a small epsilon wave afterwards. Then we also look at these echocardiographic measures, and if the values are the upper athletic references, and that's what we've just talked about, they are dilated, then functional assessment is key. The balance between the right ventricle and the left ventricle is also important, because you get this normal adaptation with the left side as well, where you wouldn't in the condition. And then some of these indices here also help us. If it's inconclusive, then we have to think exercise ECG, cardiac MRI, or ambulatory ECG. I think fundamentally, the bottom line is that the athlete's right ventricle dilates in the same way that the left side does, and it's more likely to dilate and get bigger proportionally in the outflow and the inflow in those of greatest cardiac and cardiorespiratory fitness. It's very important to remember that the right side also dilates in proportion to the left side as well, maybe a little bit more, but not to a significant degree. And so
Thank you, Doctor.
Okay.
Thank you.
Okay.
Now I'm going to translate.
Okay, I'm going to play the final video whilst you translate.
Okay. Go ahead, yes.
British cycling. Responsibility
Okay, you can translate now.
إذن وفي الجزء الأخير الذي تطرق إليه الدكتور ديفيد عن تضخم القلب، حيث يشير إلى أن هذه الحالة هي حالة طبيعية بالنسبة لممارسي الأنشطة الرياضية، خصوصا منهم ممارسي أنشطة التحمل، إذ أن القلب كأي عضلة أخرى تتضخم بممارسة النشاط الرياضي المنتظم، بينما في نفس السياق يعتبر تضخم القلب للفرد الغير الرياضي حالة مرضية. نحن نعلم أنها قد تنشأ من التهاب الغشاء الخارجي أو في زيادة السائل الموجود، مما يؤدي إلى تضخم حجم القلب. وأخيراً ينصح الدكتور باستخدام أدوات التشخيص الأخرى التكنولوجية منها والممثلة في عمل تخطيط للقلب والتصوير بالرنين المغناطيسي والوسائل المصاحبة. So, Doctor, we would like to thank you for granting us some of your precious time and for the enlightening knowledge you have shared with us today.